Thank you very much, Jennifer. Thanks, and thanks for the invitation to be here again. You had me here last year, so the fact you invited me back, I shall take as evidence of a triumph of optimism over experience. The NHS, National Health Service, it's always a cause of controversy, is it not? I think probably always best to start a speech about the NHS with an Aaron Bevan. In 1950 he said, "The NHS is a novel experiment. It is an attempt on the part of British society to reconcile two normally conflicting interests, centralised financial responsibility and decentralised administration at the periphery." That tension, I don't think actually in the NHS, in truth, ever since 1950, has been resolved. It's a task we have constantly to be working at to try and achieve that sense of national standards, national funding, national responsibility with decentralised administration, actually in this context, actually leadership. Decentralised leadership, I think, is what we're now looking for. And that's at the root of much of the political debate, and that fight between competing instincts of decentralisation and centralisation, I think, is important for all of us to be constantly realising we're engaged in that fight and that there is merit in both. The National Health Service, in the minds of the public, is something where they expect, rightly, there to be consistency, equality of access, a degree of uniformity of the character of the service they receive. But at the same time, we all know that they actually expect the clinicians in front of them to be able to make decisions. They expect their service to be locally responsive. They want there to be creativity and innovation in the service that is provided. And that can only come through the decentralisation of power and responsibility. A similar debate took place, of course, nearly 10 years ago. I'm trying to... Is Alan Milburn here this afternoon? No, okay. He was here last year. He might remember, not yet 10 years ago, he, in the legislation, I served on the standing committee of that legislation, setting up foundation trusts. You won't be surprised to know what the BMA said of it. They said it would be, quote, the end of the NHS. The Royal College of Nursing said, these proposals could lead to the creation of a two-tier health service. Interestingly, he even actually had, the government had a notional majority of 164, but it went down to 17. And I can remember that night, when it was late at night, where there was ping-pong between the House of Lords and the House of Commons on the subject. 130 Labour MPs signed a Commons motion against Alan Milburn's bill. Maybe I've got off a little lightly, or perhaps I shouldn't. Perhaps I shouldn't tempt fate. Now, time after time, rightly, people say they are pleased with the NHS, satisfied with the NHS. But just because the public are satisfied doesn't mean that all is well. Because we know there is actually a storm coming. An ageing population, a rising tide of chronic conditions and long-term disease. The number of people living with dementia set to double over the next 30 years. 1 in 3 of us being cancer patients in the future. The costs of new drugs and treatments escalating. In the 5 years to 2009-10, the cost of prescriptions for diabetes rose by 40% to nearly £650 million. And the money available to meet those challenges, we're committed as a government to increasing in real terms, but it is not in itself going to be enough to keep pace with rising demand, rising costs, rising expectations. At least it will not be enough if we carry on just as we are. We're not carrying on as we are changing. And we are changing, it's not about the bill alone. It is about a process of modernisation, of reform, of empowerment across the service, and of the way in which the service is responding. And I don't want to avoid the moment, which I think is rather important now, to recognise just what is being achieved, because right across the NHS, we are now building the future at the same time as we are maintaining and even improving performance today. And that is a remarkable thing to do, because it is, and it was always clear, that it is an immense challenge to try and deliver what is necessary in terms of the quality, innovation, prevention and productivity challenge. But let me just, if I may, I'm going to detain you. I'm not given much to using PowerPoint, but on this occasion I'm going to do so because there are things I think are better conveyed visually than just by me giving you some statistics. So let's quickly go through some of these things. An increase in expenditure over the years ahead, but it's nothing like the past. Just look at that. That's the kind of increases back then, 2005-06. What is it? An 8.5% real increase in NHS expenditure. And that was the year that Patricia Hewitt went to see the Royal College of Nursing and they booed and heckled her. It's nothing like that kind of increase now. Across the countries of the United Kingdom, those of you at a distance, going from the right, these are 2011, 12, 12, 13, 13, 14. This is extracted as is from the Wales Audit Office analysis of health budgets across countries of the United Kingdom. On the right in the orange is England as they had it. In fact, the figures are higher, 0.9, 1.1 and 1.3 respectively in England, but I won't detain you on that. Blue there is Northern Ireland, light blue is Northern Ireland, the light green is Scotland, red is Wales, a 6.2% reduction overall in real terms budgets in Wales. In fact, the Wales Audit Office said by 2014-15 they expect the spend per head in Wales to be lower than the spend per head in England. But how are the NHS performing? These are average waiting times, median admitted and non-admitted and incomplete waiting times. Those averages, essentially, they are stable. Referral to treatment waiting times, the percentage admitted within 18 weeks is above the 90% operational standard and currently rising. Mixed-sex accommodation was never previously measured. We measured it for the first time in December 2010. It was nearly 12,000 occasions when people were inappropriately admitted to mixed-sex accommodation. We've now brought it down 95%. Cancer waiting times, this is patients referred and seen within 14 days of referral, continuing to rise. MRSA and Clostridium difficile infections continuing to reduce. This is over a period down to 2008-9, now at record low levels. But the point is it's not all where we want it yet to be. These are some of the principal health indicators extracted from the OECD Health at a Glance data from November last year. Don will recall we were together at the Commonwealth Fund. At the Commonwealth Fund last November, Britain, along with Switzerland, had in the terms of the Commonwealth Fund's data, the best performing health services. Switzerland pays a great deal more than does the United Kingdom for its health service. But of course, what the Commonwealth Fund sets out to do is to assess access and equality and the extent to which people have access to a medical home and GP services and the management of some long-term conditions. But it doesn't necessarily measure outcomes. And I think Don said rightly at the Commonwealth Fund, we've got to move from volume to value. And when we're measuring value, we must focus on outcomes. And these are some of the key outcomes in the OECD indicator. And it doesn't yet put us, the green, we have some yellow, but actually we have too much red. And we want to arrive at that place where we are on this green and yellow side of this chart in years to come, where our outcomes are there. And that's why one of the central objectives of reform must be consistently to focus on those outcomes. By getting more money to the front line, the half of this on the left is the increase in management costs in the NHS through to 2009-10, more than doubling. I might draw your particular attention to these two, if I may, these 2 years here. You might remember we knew a financial crisis was coming in late 2008. Between 2008-9 and 2009-10, that's those 2 years, the NHS managed to increase its management costs by 23% in 1 year in the run-up to the election. I think that in itself ought to be regarded as a sufficient condemnation of the way in which my predecessors at that time managed the NHS. We took more than 300 million out of management costs in the first year after the election. The right-hand side shows we're going to take a further £1.3 billion nearly. It'll be a total of over £1.5 billion out of the total administration cost for the NHS. And we're focusing on clinical staff, and this is reflected into this, that there is this progressive reduction now, 13,000 reduction in the number of non-clinical staff. The number of clinical staff is reducing and probably will continue to reduce, but the focus is on increasing the relative proportion of clinical staff and maintaining and improving clinical services. Where do efficiency savings in the NHS come from? In 2010-11, I have to say this is before QIP, technically, before QIP. This is acting on the basis straight after the election. A lot of it is coming out of clinical productivity and efficiency already. A lot of it is the result of pay restraint. Where are we going to be delivering them from in the future? And you can see here a great deal of it in 2011-12 is happening in acute services. You may not be able to read all of the figures toward the back of the room, but if you look at acute services here, something approaching 4 billion of the total 6 billion plus of QIP savings in 2011-12 will be in the acute sector, and a lot is attributable also to pay and central budgets. And that really brings us to the point with QIP where you've got to realise in future years it is increasingly going to be about the redesign of clinical services to yield long-term change, not just tariff-driven reductions in cost based on efficiency savings in the acute sector. So the work being done on integration of services is not just about the improvement of quality for patients by joining up services, it is also about enabling and encouraging the redesign of service that enables us to deliver more with less. And they're being, as you can see, being delivered across every area of NHS spending. That just is further to highlight that half of that is in the acute sector. And where community services and other services are concerned, there is clearly going to be, in the future, more need for us to work together to deliver the redesign that achieves QIP savings further on. But this year, and this is this year we're looking at here, what we're seeing now is a shift that is resulting not from rationing or control of referrals or anything like that, because in the past we've seen, for example, general practice referrals to hospitals being constrained artificially, and what happens? You get increases in emergency admissions or increases in accident and emergency attendances. But across here, what you can actually see is we've got 3 years here. The blue is 2009-10, the red is 2010-11, the green is year-to-date 3/4 of 2011-12, this current financial year. Non-elective, so emergency unscheduled admissions, up, up, now down. Elective admissions are continuing to increase, but actually not at the highest levels we've seen in previous years. First outpatient attendances, very big increases, now down. Accident and emergency attendances, increases, now down. Put it all together as a total for cost-weighted activity, we're talking something approaching 3 to 3.5% increases in each of the 2 previous years for the total cost-weighted activity in the hospital sector. So far this year, about a 0.1 to 0.2% increase in cost-weighted activity. Of course that creates pressure for the hospitals, of course it does, because not only have they the tariff pressures, they are not being compensated for by increasing levels of overall activity. But that is where we intended to be, and it is now happening. Oh, that gets us back. Right. So from my point of view, and I will say, not only are we doing all of those things, but I think a lot of it is increasingly being driven by our ability to publish data, to talk about what we're achieving, to get it out there. And things like the Atlas of Variation, measuring clinical performance across outcome indicators is absolutely vital to make it happen. Now, to make this what I've described, it's happening now, but we need to entrench it, and the bill is absolutely part of entrenching it. The point is not, the bill is made for man, not man for the bill. The point of the bill is to enable people in the National Health Service to do the things that they know they can achieve. They need to have the responsibility to do it. We know that the challenge in terms of redesigning clinical services for improvement in the future means that they have to have the benefit of that kind of transfer of responsibility, that decentralisation of responsibility. Many of the changes in the bill, often for an audience here, no doubt, when we talk about commissioning and tariff, it means a great deal to you, but I have to tell you out there, it does not. People don't know what commissioning is. They didn't talk about commissioning in the past, really. The black box called what happens inside the administration of the National Health Service was an absolute mystery to the public. It is, frankly, we ought, I think, probably to be really enthusiastic about the fact that there is a really lively debate about the accountability of the National Health Service for the future, because it never had that kind of accountability in the past. I've been there as a politician. I've been there asking ministers who was responsible when things go wrong, and they say, oh, it's local management. And then and locally people say, well, if it's local management, how do we impact on them? And the answer is they never did. They could barely impact on them at all. They hardly sometimes even knew who they were. But I think the principles of what we're now going to do are very straightforward. We're going to take power from politicians, give it to the doctors, nurses and health professionals who are responsible directly for looking after patients. We are going to give people more control of their own health care so that there is genuinely no decision about me without me. And we are going to focus relentlessly on clinically relevant outcomes. Of course, people will say, that's all very well. We agree with the principles, and organisations the length and breadth of the land have said we agree with the principles, but the devil's in the detail. Well, so let's look at a couple of the details that people say most concern them. One they say is that competition means privatisation, and privatisation means that people will be charged for their care. It's absolutely not true. The NHS has always been and will always be a universal service, free at the point of use. I'm committed to it, David is committed to it, the government is committed to it. The very first line of the bill reiterates that the NHS care must be free of charge, and there is absolutely nothing in the bill that would permit that to change. The second concern, they say, is that private companies will cherry-pick the most lucrative things on offer, leave the NHS to pick up the pieces elsewhere. Now, I know that for some people, the idea of competition at any level in any way is a matter of ideological principle, and they won't have it. Those people I will never persuade. But I think actually those views are held by a very small minority. For most people, if you offer them treatment free of charge as NHS patients in a high-quality hospital, they will take it. Actually, we don't need to speculate about that. We know that is true. The NHS Choice offer has demonstrated that very clearly. It doesn't matter to the patients if the hospital is owned, as it were, by the NHS or by a private company or indeed a charity, a voluntary organisation, as long as it is part of the NHS and paid for by the NHS, and as long as they receive high-quality care and they know that it is free to them. It would matter if the long-term result of that choice led to a hollowing out of NHS services, if it meant that over time there would be fewer services available or of poorer quality. Now, it's a bit like what happened to the buses when they were privatised back in the 1980s. Now, far be it from me to criticise the policy of any former Conservative government, but actually it didn't work as intended. In city centres with lots of people and lots of companies, the result was more routes and lower fares. But in more rural areas, where perhaps a handful of people made a small number of journeys a week, the bus routes closed, leaving people stranded. And people imagine that the same sort of thing could happen to the NHS. It can't. And it won't, and I'll tell you why. When you can compete on two things, price and quality, how cheap you are and how good you are. When it came to buses, a bus journey is a bus journey is a bus journey. You just take the one that turns up, unless another one is cheaper. So the competition essentially was on price, on those who can offer a basic service at the cheapest price. So the bus companies, who in this case were the ones who set the prices, undercut each other, and actually there was considerable turbulence in the system as a result. Routes that didn't pay were cut. Now, if that was the way competition worked in the NHS, I would be in the front of the queue denouncing it. But it won't. That is not the way it will work in the NHS. For NHS services under any qualified provider, a private provider cannot undercut an NHS one because the prices aren't theirs to set. They'll be set either nationally by the NHS Commissioning Board and Monitor or locally by commissioners. And in the NHS, with price taken out of the equation, the only way you can compete is by being better. by focusing on the individual needs of patients, delivering higher quality services, being more innovative, and indeed better integrated with other local providers. That is indeed part of what patients and commissioners themselves are looking for in terms of quality. If you're better than the rest, then you're far more likely to be chosen by patients and by commissioners. And whether you're the best or one of the rest, the pressure will be on you constantly to raise your game. And don't forget, there will only be competition where local doctors and nurses together through the clinical commissioning groups themselves deem that it would be in the best interests of patients, which is why when you look, for example, at the toolkit produced by the Office of Health Economics just 3 weeks ago, gives people a very clear picture of where competition is appropriate, where it's not appropriate, and how to use competition to deliver quality. And we don't need to speculate about this. The evidence is there. We knew in the internal market in the early 1990s that the opportunity to compete on price and quality led to a focus on price to the detriment of quality. We have seen through the elective choice programme, on the basis of a tariff price, the opportunity to see what the impact is of competition. And as Carol Proper and Zach Cooper and others have demonstrated, it is about improving quality and indeed management performance as a result of competition in circumstances where it was a fixed price system. Now, if any provider, NHS or otherwise, wants to succeed, they will have to provide the sort of integrated services that clinical commissioning groups demand, working closely, GP surgeries, specialists, social care organisations. I must say I was quite struck the other day when I was West Hampshire Clinical Commissioning Group, and two of the things that were just said literally in passing about what was happening. One of the clinical commissioning groups said to me, well, we sat down as GPs with the orthopaedic consultants from the hospital and explained to them what we wanted. And they said, why did you never tell us? Because they had never had that conversation. Because the GPs had talked to the primary care trust managers, and the consultants had talked to the hospital managers, and the managers had talked to each other in language that was all about targets and budgets, but never actually about how the services should be designed. And the other was really interesting, was a GP who said, well, actually, I've got a social worker who's told me that in 20 years in social work practice, he's had more conversations with general practitioners in the last 9 months than he had in all of the previous 20 years. So the opportunity for integration and for health and social care integration is real, and it's now. Now, you'd listen, when people argue about the bill, you'd imagine that the NHS was somehow going to be disintegrated. It won't. How often do people miss out on local help because their GP doesn't realise what's available? In future, they will. The NHS 111 helpline, piloted in several places already across the country, will make a big difference, bringing local services together, not just that it's a single gateway to accessing NHS care, but that behind it, for the first time, you create a truly comprehensive, capable directory of services, and you give people a clinical pathway-based system so that they and professionals can be confident that people are getting to the right care at the right place at the right time. And if private or voluntary providers want to provide services locally, they need to be a part of that. They need to be a part of integrated service design. Otherwise, why would patients or commissioners want to use them? For the first time, the bill will require commissioners and monitor to secure integrated services where it will improve quality and to reduce inequalities, including inequalities of access. It will be part of licence conditions to do this. Take someone who's being discharged from hospital. The hospital, GP, community care, social care, all need to be involved and all will be required to work together. Far from undermining integration, which is patchy, it's not that it exists at the moment. Actually, it will demand it. And if a private company wants to be part of that, they have to work hand in hand. So whether it's down to patient choice or meeting the demands of clinicians, the healthcare providers who will succeed in the new NHS will be the ones who integrate the most successfully, who innovate the most creatively, who push the boundaries of what is possible and never stop pushing. Competition in that sense will work because power lies in the right place with clinical commissioning groups. Now, I know last year at this conference, many of you were pretty sceptical that clinical commissioning groups would actually be any different from PCTs. Let me just be clear about this. The bill is a necessary step to the devolution of power. not a sufficient one. I am determined there will be a proper transfer of power to clinical commissioning groups and to health and wellbeing boards. We will require this of the board through the mandate and through the relationship with the department. That is part of the Secretary of State's ongoing stewardship of the NHS. We will be holding the board to account not only for financial control and for improving quality and outcomes, but also for how well the board transfers power as part of the transition. So if the bill is passed, changes are happening. What will the NHS look like? To be honest, for many patients, much will look the same. They'll still go to their GP. They'll still go to A&E if they have an accident. They'll still dial 999 if they have an emergency. And an ambulance in the same way will come to get them. Changes often will be more subtle, but I think they will be increasingly effective over time. If the bill is passed, the power to change things will be in the hands of local clinicians. They will be the ones changing local NHS services. Governments have tried to encourage this in the past. They've tried to get GPs to take control through things like practice-based commissioning, but they didn't happen. Primary care trusts didn't let it happen. That's why just adding more clinicians to the boards of primary care trusts would never have done. The power was still in the wrong place. The legislation is still in the wrong place. It's still the Secretary of State's power that can be handed out, taken back, controlled at any time. It is the transfer of power under the legislation that puts that right. When the bill is passed, patients in the future should have a better and a more accountable experience of the NHS, able to access a wider range of providers, all free at the point of need, tailoring services to their needs, experiencing a more integrated service, everything from dialing 111 to access non-emergency services, to having their NHS and social care providers planning and delivering care in partnership. More information, online or through their GP. I had a fun morning just last Wednesday seeing some of the new maps and apps that came forward as part of the competition to see how we can enhance patients' ability to use new technologies to access information, choice and services. And patients will have that, more choice and pushing themselves for greater quality. As a matter of course, that will give patients, if we get it right, more involvement and control in their own care, shared decision-making being a reality. Choice is made with their doctors which drive change across the system with best providers rooting out poor performance. And we must root out poor performance, and we've shown that we are determined to do so. And they will benefit from fast improving clinical services driven to new levels of performance by a huge increase in data on clinical outcomes and a new era of clinical leadership. If you were to say to me what I think in reality will make perhaps even the biggest difference, it is the simple fact that we publish so much more and better data, and we have clinical leaders and evidence-based approaches across the NHS where clinicians, principally clinicians, but also managers, increasingly know because the data is out there, it drives them to improve their performance. All of this means they, far more than they do today, get for patients the right care at the right place at the right time. And when we can look internationally at our performance and say we do genuinely not only deliver the most equitable service anywhere in the world, but the most excellent service anywhere in the world. Thank you very much.